So I just want to start out by saying welcome to Medicine Grand Rounds for this week, which is the final week of Grand Rounds for this academic year. So I want to start out by thanking everyone very much for your participation in Grand Rounds. I think it's been an exciting year. And I also ask people to really feel free to put ideas in the chat for topics that you'd like to hear for the next academic year, not at the cost of listening to our visiting professor, of course, but or email me. I'm really anxious to continue to set speakers that are of interest to everyone and are meeting the needs and the newest ideas in our fields. Also, any feedback on formats and things like that is greatly appreciated and helps our committee work together to select next year's roundup. So with that, I would love to, I'm very excited to have the visiting professor from hospital medicine today, and I'd like to turn the introductions over to Dr. Dan Hunt, who's the division director of hospital medicine and known to all of us. So Dan.
Thank you, Wendy, and thank you to the organizing committee for allowing us to have a visiting professor twice a year. Just as a little bit of an introduction, twice a year we invite nationally prominent academic hospitalists to join us in the division to share their wisdom and to simply interact with us as a group. I should thank Dr. Erin Kim, who leads our working group on visiting professors, for great work in arranging this visit. And I'll give a few brief introductory remarks for Dr. Benji Mathews. Dr. Mathews completed internal medicine residency and chief residency at the University of Minnesota. And then he joined the HealthPartners group and has risen to be the chief of hospital medicine with Regents Hospital of HealthPartners and is the director of point of care ultrasound for HealthPartners. In fact, he gave a terrific session for us just a couple of hours ago on point of care ultrasound. He's an associate professor at the University of Minnesota. He's known as a master clinician with expertise in diagnostic reasoning, diagnostic error, and point of care ultrasound. And he also has a passion for medical education, care delivery, quality improvement, and global health. It's quite a portfolio. So I'm going to turn it over to Dr. Mathews. We're really excited to hear your talk. Thanks for being here.
Appreciate the kind introduction. I am excited to be here. So thank you to Dan and the team with Aaron, Hila, Tamika, Dustin, and all their invitations and support in setting up this virtual day with you all. I wish I could be there in person, but grateful to connect via media, which fits well virtually, right? That's a talk today. So I have no disclosures other than I'm still learning and navigating through all this. So it's going to take some time for me to process quite of this as well over the next as it evolves. As we get started, over the last year, I've learned to do a land acknowledgement. As we gather together in our various places, I want to be mindful of the lands we are gathered on. If I was presenting in Atlanta, I would look up the history of the land there and the original inhabitants, the Muskogee Creek people with their language Hitchiti, one of their multiple languages that perished right over the years with the invasion and genocide. Since I am presenting from Minnesota, I acknowledge I'm on the land that's formerly occupied by some of the visual imagery here by the Dakota people before the establishment of HealthPartners or the University of Minnesota Medical School. So what this does for me is it helps me level set my mind and maybe our minds on the history that precedes us. And especially when injustices have been done, especially on a day such as today, 1 year from the murder of George Floyd, who was murdered just 5 miles from my home. So really maybe put on spectacles of equity is the call here as we learn on a topic and share together for the good of all people. Our learning objectives are as follows. I hope you'll be able to envision the spectrum of virtual care and who may benefit, recognize the skills using virtual care, including the concept called Webside Manner, and how medical education programs may adapt to incorporate it. Evaluate the appropriate uses of virtual care, keeping equity as a forethought. To achieve those objectives, here's our roadmap. We're going to overview virtual care, Webside Manner, lens on equity, then alternative care models and innovations. Here we go. Now from some audience participation. You thought you'd get off easy here, right? So use the chat box to enter your thoughts. as I read this next quote, I want you to guess what aspect of medicine or tool we use is being referred to here, right? Maybe you already know this, but put it in the chat box. That it will ever come into general use, notwithstanding its value, is extremely doubtful because its beneficial application requires much time and gives up a good bit of trouble, both to the patient and to the practitioner, because its hue and character are foreign and opposed to all our habits and associations. What was that about? Let's see here. The chainsaw. I love it. Computer, EMR. Yeah, gosh, it's such strong opinions coming out. That's good. One person did get it. It is, about a resistance that goes way back in the London Times in the early 1800s. This was commenting on the stethoscope. And you may think, this is not applicable to today. Well, I've got news for you, and we'll get to that shortly. All right. So does virtual medicine undermine the ritual that we so prize of bedside medicine, right? So as you can see in this famed 1891 picture depicting a Victorian doctor as he's observing that critical stage in the patient's illness while the patient is gazing at the periphery or from the periphery. So in this new world, we'll have some new cameos, appearances by Dr. Kim with some virtual tools. You can see in her suit, she's putting on some virtual tools. She's connecting with that patient there. In the background, looking suspect is actually someone who looks awfully similar to that prior picture. It's Dr. Dan Hunt himself. And he is wondering if the ritual has gone too far and we've now lost the art of the bedside examination. All right, so what are we talking about? Discussion around telemedicine can be manifold, lots of different angles we could take, yet foundations, right? Essentially, it's the use of virtual tools to provide clinical care to patients, regardless of location. And here's a colleague of mine connecting with a patient from his home in St. Paul, Minnesota, and it could be done in the hospital itself, yet to a rural community hospital 100 miles away. Telehealth, I've been part of it for about 5 to 6 years, pre-pandemic and through the pandemic, and there's a lot of different terms you can use interchangeably, including the American Telemedicine Association uses these various terms. Others like CMS like the word telehealth as a broad term. And you can note a lot of the interconnected terms here. So asynchronous store and forward refers to the storage of digital media, photos, videos, and patient data that can then be reviewed really asynchronously by a healthcare provider or synchronously. A BAA or business associate agreement is important for safeguarding privacy. And we'll get to that shortly as well. And especially when regulatory aspects are on telemedicine. And then the HPSA refers to that shortage areas. Here's the very basic flow of telemedicine operation that a clinician has a video capable hardware connected via video communication software linked to a patient. Very simple, right? Yet there are different platforms and video solutions. There's no clear superior video platform. What we can say about these is that they all need to incorporate some key elements. They need to be easy to operate. Almost any given attribute, the EHR, EMR, it's not easy. It's going to be a painful experience. And some are still thinking it's painful. Cross-platform, it needs to just be translatable across different modalities. So patients need to be accessible where they're using the latest iPhone or in hospital room with a computer or Windows XP or you name it, web camera from a decade back. It needs to be cross-platform. And HIPAA compliant. It's an important one, right? Most video platforms is contingent on that term, BAA, that's in place to safeguard patient data. Now, as many of you probably know, the Department of Health and Human Services implemented a policy of enforcement discretion with the use of non-HIPAA compliant platforms. As of January 2021, this was also broadened to allow web-based scheduling platforms. Unfortunately, we do not know how long this policy will last. The hope is it'll be at least through the end of the public health emergency and potentially longer, so more to come. So let's reframe the tech. We just had that other slide that looks similar to what a clinician actually needs, right? The clinician counterpart is it needs to be easy to onboard. Tech must be easy to onboard. It must be location flexible. It doesn't have to stay in one room. It can be mobile, can go to various arenas in the hospital and care systems. And we'll talk about later, even in the home. And it means multi-user functional, so multiple people logging in ideally. So we've covered some technology requirements. And what about the actual patient interaction? Here's my colleague, Dr. Cregan Ryerson, handing off a patient off his care of his telemedicine to the telemedicine hospital on the camera there, Dr. Doshi, at the end of his shift. So let's dive into a framework, but I'm going to actually use learners because I think a fair bit of you work with learners, residents and students. So virtual exam. How do we do this? Patient, they can be an active part of the physical exam. If you're looking through a technological device, video chat, and the patient, you can have them press on their belly. It can sound foreign to you. Well, we can have them participate in the process, but other more complex things can be hard to do. The resident students can be in the room, they can be precepted by the attending, or they can be examining remotely. The teaching provider, that's similar to the learners, can dynamically engage or disengage depending on what's going on there. And there's other facilitators. You can use digital peripherals, and we'll talk about some of those coming up. So it can be used both as a standalone virtual, so you're just doing for selected examinations, or you can do a complete H&P. Maybe mind-boggling to some, but it does require a skilled bedside facilitator and often those digital peripherals. In my home with telemedicine, we have some audio there that I can listen to the heart and lung sounds, remote ultrasound use. There's some peripherals that are set up to help facilitate that. Stethoscopes, otoscopes, ultrasound dermatoscopes. All these can be used with proper training and supervision. It can be done, and I think it provides a care across the different locales. And you need to have effective communication between stakeholders if you're to deploy this, and just to make sure people are on the same page. Moving on, Webside Manner. Let's walk through a case study. We'll walk through a virtual care with residents to really bring home some points here. Pre-COVID, many of us had a routine, right? Including those of us who had residents working with us or not. And we rounded often together, often gathered in spaces together, met in large groups together, have people like me come over in person, right? I think things have changed, right? And in the COVID pandemic, it's more isolation. We're more covered up. Pre-COVID, this is how many of us looked like. Very handsome, makeup on, hair perfect. Post-COVID, no makeup on, less handsome maybe, lost our beards. This is the image of the first week on COVID wards in March of 2020. Not too different still. At the start of my shifts on clinical service with our residents, I've been adding some new components over the last year. And these are our new workflow. First, I check for symptoms, right? Personally, my household members, take a temp, make sure I'm up to date on the guidelines. Next, I get my mask and eye protection on. And the last piece is the last change that's a crucial part in this pandemic that at least our organization we're part of, is telemedicine equipped rooms. Are patients in those rooms? How can I use virtual care here? So students in the pandemic, mostly from the University of Minnesota Medical School and affiliate sites, they had a unique situation. There's a balance between your educational needs that you're trying to go for and then protecting them, right? And what's our argument here? So I'd hope that this argument may persuade our listening group that virtual care and the tools we have can help supplement, even protect our trainees while continuing to prioritize patient care and education. So for internal medicine residents, we use video visits to complement our training goals. Here's a team tele-rounding with a patient and checking in on them during their day of service. And the patient is able to interact back with the team through an iPad that automatically answers in the room. Pre this team, the team had called the nursing staff to say, give the patient a warning shot and also say that, is the patient ready for us? And then there's an automatic answer. The teams are able to check in on the patient so rapidly and save time crossing floors and even communicate the morning and afternoon. We saw more communication occurring because of this than less. To guide our teaching teams, we thought there needs to be some framework on which patients would be most appropriate for virtual visits. Well, here's our decision tree we thought we'd put together to help put that together. So first, the team needs to decide whether the patient needs an immediate in-person assessment or not. So you have a critically ill patient, end of life care discussion. Telemedicine is probably not the most appropriate modality, right? Well, the next decision is, do they require an in-person assessment? And so I think the idea of foregoing a physical exam may be counterintuitive to most of us in internal medicine, yet in certain circumstances, telemedicine can still provide appropriate level of care. And the decision tree kind of guides us through the next step on how to connect the device with the patient and clinician. All right, but you have questions. You say, well, you ask, well, early on, Should all our learners be assigned COVID-19 patients? How do you optimize assessing learning from conditions that require human touch? Should all members of the teaching team be donning PPE and entering the patient room? There's a lot of questions we still have, right? So enter this term called Webside Manner. That's the virtual analog to Bedside Manner. And just as Bedside Manner encompasses much more than just one's appearance in front of a person, Webside Manner, I think, really transcends how you look and appear on the camera. So empathy, understanding the totality of the encounter and translating it through the virtual medium is what we're talking about. So enunciating, speaking a bit louder, right? Those are things that we move to do. Adjusting, looking into the camera, making eye contact, right? Even the patient's face may be on the screen below, but you need to kind of look up there. Here on the Zoom, I'm on the bottom right here, but yet the camera's up on top, so I'm looking up there, right? Hypothesis-driven history taking and visual physical exam is what we're talking about. It gets very creative with exams. So it's hard to be an exam automaton when you have to be creative with each component. So I think there's a beauty here that we have to kind of open up here. So Webside Manner, what's the setup like? Well lit setting, ideally that's private. And this is an example of a home environment, but it can also be done in the institution, in a hospital. Uniform lighting that allows the patient to see their face, hopefully a light in front of your face that allows that. And if there's light in the background, putting it to the sides are probably key here. And the background that is not too distracting, right? So the word presence in Webside Manner we talk about refers to the purposeful practice of awareness, focus, and that attention. And the intention of all that is to understand and connect with patients. So telemedicine may divest away from physical presence. We may go farther away from physical, but we can still provide that gift of presence. And so enter the word telepresence. And you may Benji likes making up all these words. Well, some of it is putting words together from our historic old to potentially a new era, right? Telepresence, I think, captures interpersonal skills and the camera component to create that visual eye contact as needed. So once a visit begins, sometimes just saying, hello, hi there, establishing rapport with the patient is key. And then I often just start with, hey, acknowledge the novelty of the medium. Hey, this is new, or just say, this may be new to you, but I want to help you through this. Sometimes in situations where it's a supplement, I tend to say, I'd love to be in person with you tomorrow or this afternoon, especially when it's a supplemental situation. Agenda setting. As with clinic visits, you say, I want to make sure we're on the same page about what we want to cover in our visit, right? Listening and minimizing interruptions. And I think most of the time we interrupt, right? We don't listen to the patient's active posture of trying to express something. And active listening involves some level of some open body position, not hands crossed, right? And sometimes orienting towards the patient, not just sitting back here and looking at it from the side, right? You're trying to look towards the patient. They may not see your full body, yet your nod, your facial expression, you're conveying the active listening is key. All right. Webside Manner continued. I would encourage us to be direct and explanatory in our statements. Example, I'd like to check for pain in your belly. Your nurse will start pressing firmly in the right upper side of your belly. Tell us if it causes pain. Now that's if the nurse is that facilitator, if I'm going through virtual medium. It could be another colleague, a clinician. In certain situations when it's a remote follow-up, it could be the patient themselves, right? Second thing, explain every action, such as looking away from the screen, because I'm just going to turn and look at your test results. Otherwise, they're going to wonder, where did the doc go? Is he not paying attention to me? And so explain every maneuver so it avoids you being distracted or looking distracted. So there's a lot of applications with telemedicine. I'm going to rapid fire go through some of these. If you have further questions, I'm happy to field them towards the end or in another context as well. Table rounds. This, I use a simple application via an iPad and call into a larger screen device situated in one of the teaching rooms. You saw one of the images there during some of the table rounds. I mostly do walk rounds, but times when we do table rounds, I'm able to take off my mask, right? I have a mask, I take that off and my team can see my face, right, in this pandemic era. And I've also done quick chalk talks virtually on the day we had 3 residents, 2 pharmacy residents, 2 medical students in the room. Well, it's packed. How do you do physical distancing? I go to the office. I try to talk into the room via this medium. And this is kind of a display of how that was done in that time. Walkarounds. The beauty of telemedicine is the speed of connectivity in the rooms, going from one end of the hospital to the other, right? Oncology to neurology patient in seconds. It takes some planning. So on the first day of the clinical week, I set some expectations guidelines on telemed, and then find the appropriate patients, use that decision tree, ensure the device is on in the room, and then inform the patient and the nurse. Then checking in towards the end of the day, remotely from anywhere. I tend to do a check-in. If I do morning rounds or morning table rounds or walk rounds, I check in the afternoon. And instead of going across the other side of the hospital and seeing them, I tend to, well, partly I'm also trying to teach and exemplify telemedicine. And so I tend to use iPad on a stick, and I tend to remotely connect with them anywhere in the hospital. And I'm into their room, allows me to connect again with my mask off, periodically do other additional concepts as well at that time of the day. Oh, what I love, broadcast teaching cases in historic theaters. For rounds a few weeks back, we had a patient with a marked facial neck rash that only the resident had seen. We were able to virtually call into the room during table rounds to together see and learn from the physical exam findings. You can also multi-call, so multiple teams can see the same patient via technology. How's that for a new theater of old coming into today, right? COVID-19 patients, this is old news for you, but yet with medical students in our institution, medical students are still not allowed to see COVID patients. They can still learn from cases by visually interacting with patients. I tend to even have my student from a couple of weeks ago. They were presenting, writing their notes. I was their hands and feet. So I would go round with the patient. They would talk through the telemedicine medium, connect with the patient. And if they asked me to examine their lungs, I would listen to their lungs and talk to the student. Yes, there's other learning objectives that need to be met, and they would do that with non-COVID patients, but they still get to learn from our COVID patients. And last but not least is point of care ultrasound, and we'll get to that later. So in this talk on iDoctor, let's dig deeper into the iResident portion and look at some preliminary data. You're like, well, does this even work? Well, here we go. I'll discuss some in our pilot program at HealthPartners in St. Paul, Minnesota. Again, the program, the implementation aim was to assess telemedicine virtual rounding with a traditional rounding team on inpatient teaching teams. So our workflow was as follows. We'd first train a framework for telemedicine and talk to our chief residents and residents about it, then implement telemedicine during rounds, evaluation surveys. Simple, right? Okay. So here's our findings. In our setting at Regents Hospital, teaching hospital in St. Paul, Minnesota, with over 400 or 500 beds. It's in the Department of Hospital Medicine, a department that crosses HealthPartners with 220 hospitalists in 12 hospitals. This study was done at Regents Hospital, which was the main hub site. We had a pilot case study during the pandemic. Small sample here, 17 medical students over a 4-month period. We found virtual rounding, a total of 82 times was used, specifically for virtual rounding with just the resident team with the patient, 77% of those times. This included group walk rounds, table rounds, teaching with the patient, bedside ultrasound. And for virtual rounding with the team and attending 19% of the time. Again, the latter is when we're doing table rounds with the attending. Often this was just running the list at the end of the day. So what else did we find? 94% found that telemedicine was useful, and free text responses coded into thematic groups show some descriptions of why the learners found telemedicine experience valuable. So information gathering. The students learn to, and the residents learn to really pertinently look at virtual and physical exam tools and how do you actually use them in the virtual era. They learned this concept of Webside Manner, verbal and non-verbal skills, telepresence. A little bit of tech, gained proficiency with the app and platform. And we'll cover this a little bit further, but exploring health disparities and creative solutions for patients, particularly those that suffer from baseline health gaps and disparities. Well, if you don't believe me yet, and several studies show some positive impacts of virtual learning, and yet there's more needs of work to be done, right? And a lot more outcomes needs are TBD. And so more to coming up. All right, there are training programs though. Groups around the nation are building curricula for telemedicine, and And my quick search, I think Emery's also looking through that as well, if not already. The urgent need has created things at Cleveland Clinic, at Musk with the South Carolina, sorry, it's close to your neck of the woods, has done work in this area as well, and a detailed module set as shown here, including things like legislation, regulation modules, team-based care, and community partnerships. So this is coming. If our learners are doing this, how much more do we as staff need to be a part of the conversation? Okay, again, let's review. Telehealth is only effective if clinicians get the critical information they need to assess the patient's health, right? They're able to virtually examine a patient as if they're standing right at that bedside. And depending on the settings, often in hospital medicine, there's a bedside nurse, a clinician extender, learners at the bedside. The remote clinician with their dashboard computer, HIPAA compliant peripherals, are able to connect in a way that augments telemedicine. So again, there's all these peripherals you can use. Again, they can use video conferencing and one more thing, which is bedside ultrasound. I'm going to dive into that just a little bit as one case example that can help pull that thread to, and not a ton on it, but just one slide or two here. As you know, point of care ultrasound has been used in medicine for the last couple decades, more so in the last 5 to 6 years, you've seen that grow. We've seen it grow in the ER, in ICU, and I know at Emory you have some great leaders in this space, Dr. Malik Williams and more. Hospital medicine clinicians are gaining skill set along with the critical care staff. And this pandemic has grown teleguidance, especially when you don't have in-person courses and support. So a virtual ultrasound platform enables what happens, a trained clinician or hospitalist to connect with their learner or peer at the bedside. So the bedside scanner places a video call. So say I'm scanning a patient, they have a question about, does this patient have congestive heart failure and how is their pump doing, right? A remote trained physician can then view the bedside ultrasound and guide and remotely adjust and support the learner or the peer at the bedside. All right. This is extended to options such as an ultrasound consult service, a diagnostic ultrasound service. If there's limited trainers or faculty in one locale, you can have support through a consult service that supports the other side, right? And we've done that in resource limited settings and beyond into global health as well. Recently, a course in Alaska and another one in Singapore, able to train and support staff across the oceans as well. All right, so does it work? Well, telemedicine looked at a little bit. Again, here's the data. Our site, Regents Hospital, Department of Hospital Medicine, with nearly a dozen learners over 4 months and 50 hands-on training sessions, of which approximately half of them were in person and other half were virtual hands-on. What do we find? We found that learners overall reported increased knowledge of ultrasound indications, comfort performing ultrasound, and augmenting their physical diagnosis. More fascinating was over 80% looks like, perceived that virtual hands-on format was just as effective, if not more effective than in-person format. And I think a quote to really drive this home, I like the ability to learn on the go and to see any of my patients as a follow-up, scan them and virtually reach an attending quickly to just help me supervise me at the bedside. That's what we're hearing. Do we believe that? Do we want to push into that? So feasibility, well, things have been done. Right? In the BMJ prospective observational study with 1,300 consecutive patients in 3 remote areas, handheld ultrasound performed at the bedside by physicians with remote virtual expert support was feasible. And also reduced unnecessary, more comprehensive ultrasound studies. The other one, another study looked at, I think of 17 physicians who were provided 6 hours of hands-on training with ultrasound. 9 were taught on site and 8 were taught through an online system, through a transcontinental tele-ultrasound system. The quality of images were graded. There was no difference between the 2 groups, right? Again, bedside ultrasound, I don't want to put this more than that. It's one of many examples that the rewards are definitely possible with virtual diagnostic tools. We've covered an overview and how we've adapted to the virtual era. Next, we've discussed Webside Manner and the applications of telemedicine. The third topic in our roadmap on virtual care is on equity. On this day 1 year ago, George Floyd was murdered. Again, less than 5 miles from my home in the Twin Cities. the juxtaposition of his murder and this cry that he had, "I can't breathe," right? That also, and just all the disproportionate way we've seen COVID really impact on people of color, under-resourced groups, really highlights how deeply entrenched systemic parts of racism in this country is, and it's also its impact on healthcare. Virtual care is not immune from that. And so realistically, the virtual exam does have limitations, and we'll cover a couple of those and get into that equity pieces as well. Again, we have to know the times. We covered that in that decision tree. It's not every patient virtual care. If you have an option to supplement it, choose the right supplement. Second, know the technical aspects. Yeah. If you have robust IT support, great. If not, do you know the simple turn on and off, basic audio visual disconnections? And how do you orient the other team members? So the nursing staff, any touch point with the patient should be able to support that patient. Assessing their basic digital literacy is also important before you start. And then in the United States, there's also already been disparities for people of color and non-English speakers, and your institution covers this quite a bit in terms of how your diversity and equity committees there. The challenge, again, is if there's not a careful consideration for these groups, that could be exacerbated with this technology we put on, right? And I think those that don't have access to smartphones, those that don't have telemedicine capable carts, or areas that don't have that, how do we help patients overcome technological barriers? And I think the mantra that I tend to use a fair bit is equity still needs to be a forethought and not an afterthought. It's in any build that you do, and not at the tail end. Hey, what about this subset? Well, we've kind of built it out. It's not really, can't scale up the mountain now. And there's always going to be a tension between speed and equity. Getting solutions quickly has been a staple during this pandemic. Speed, though, comes at a cost, right? Often at favoring individuals with greater privilege who live in arguably well-resourced areas. And so relying on those existing places of healthcare delivery also means those who are uninsured, lack of primary care, or live in under-resourced areas are going to have more barriers to access. All right, I'm not going to preach more than that, but I think the last other piece I would just say is on interpreter use. There's language is an important barrier to telehealth use. And so again, the importance of assessing perceptions of how do you adopt this in let me give you an example. So there's a study on African-American patients and Latinos' perception about telehealth. African-American patients express more concerns about confidentiality, privacy, and physically being unable to see their physician than Latino patients. And the argument was made this is potentially due to lower level of trust in the communities resulting from a legacy of historical abuses in the medical system. So, and that doesn't mean it's uniform every other community of African Americans, but understanding community-specific factors can help influence the acceptance of virtual care technologies and implementation. Because you want to eventually get at all people, all patients, and support them. Flipping it, going from disparities gaps that are maybe exacerbated to what are areas that could be closed slightly. Here's an image of the Twin Cities, Minneapolis, St. Paul, with care extending from HealthPartners family hospitals across the divide to our neighboring state of Western Wisconsin. Again, it's hundreds of miles that gets traversed with this. Telehealth transcends geographic constraints, right? And helps support less resource settings to operate really at their highest capability to optimize population health, right? So the hospitals we take care of an organization, again, 150 miles away, and they are adopting virtual care. So a term I want to just introduce is a term called structural urbanism, a term from Health Affairs, and against the elements of current public health and healthcare systems that systematically disadvantage rural communities as they are trying to enhance, rebuild their healthcare infrastructure. And so this is that bias that's in this article they talked about towards cities, and that the focus of the health of individuals over populations exacerbates rural health disparities. So sometimes we need to put in investments into some of these communities may not have the density, but it helps the larger population and connects and improves that access to care. And you have to mitigate some of these biases, and some conversation around this is needed again. Again, equity as a forethought involves topics like structural urbanism. Population health. Rural community residents have limited access to healthcare. We've known that, and generally lower average incomes generally lower educational levels, less insurance coverage, which what does that do? That leads to poorer health outcomes, right? Using a telehealth program in Utah, this is in Mountain Health, patients with cancer benefited from substantial monetary savings. And so patients demanded more, right? They want some sort of access to care and helps fit into their lifestyle. They don't have to take time away from work. They can probably hop on a virtual visit and a conversation with a trained physician. They can visit with families. Families can see patients. If their patient's going to go visit in person, the family can log in remotely. Communities benefit, right? It keeps healthcare local, and local facilities can retain that revenue from a cost margin standpoint. And essential services are built in those communities. Depending on resources, again, pathology procedures could be completed by local physicians with appropriate oversight. On equity, closing on this point, telemedicine shrinks the distance between under-resourced people groups and clinicians, right? It brings care to special populations that otherwise wouldn't get care. Correctional facilities, schools, veteran groups, right? Here, this image, United States has the largest correctional population in the world, and many inmates lack access to timely healthcare. The gold standard has been said is loads of doctors going into prisons. But is that feasible? First, we don't have enough physicians. Secondly, after traveling to a detention facility, and we've done that here locally, going through security, after getting set up, it takes, honestly, I can maybe see 3 to 4 patients in a day rather than 15 if I had stayed in the hospital. So in many cases, prisoners who require specialized care have to leave the prison to access it too, right? So that's also several times of travel. So telemedicine really bridges this and is a powerful closure for many of these gaps, including prison care. All right, we've covered Webside Manner, and we've covered overview, and we've done health equity. High level here, right? So probably going to leave you with more questions than answers. If I've done that, probably done my job well. And I won't have all the answers either. So here, the last part, I want to walk through a case study with virtual care and care models and innovations, and some take-home points in the end. Imagine you have a 60-year-old gentleman hospitalized for shortness of breath and treated for congestive heart failure. On hospital day number 3, he is still 15 pounds up in his weight and short of breath and not at his dry weight goal. And he is anxious to go home and be around his family members and his community. Well, the hospital's at capacity. I know it only happens in Minneapolis, St. Paul. And there are pressures to discharge patients home. And again, it's unheard of anywhere else. This is uniquely a problem in the Twin Cities. So yet just imagine with me, and when this happens, this double pandemic with COVID and racism, really a lot of stress on the capacity, and optimizing access and flow came up. And we've tried in the past to improve capacity and decrease length of stay by various diagnoses, improving order sets, helping doctors and nursing staff work with care managers. Yet we've really not seen a large gain in decreased length of stay. So insert virtual care again. And this is the ability to deliver care in multiple locations, whether inpatient, outpatient, or the home. And I want to introduce you to the Hospital at Home program. This isn't new news. Others in the nation are doing this. This began in Hopkins in the mid-1990s. Brigham and Women's Hospital had the first US-based randomized control trial on hospital home programs showing lower readmissions rates. A couple more articles have come out since. This program is designed to really treat acutely ill patients in their home in lieu of the ER or hospitalizations, really shortening length of stay, ER U-turns, the availability of 7 days a week, staffed by, in our institution, hospital medicine, RNs, and community paramedics. One case example doesn't mean that this is what everyone needs to do or has resources to do. Here are the services that provided through the Hospital at Home program. I'd like to highlight the ability to provide IV meds and the opportunity to really delve into the social determinants of health. So quite a bit of capabilities that can be done in the Hospital Home program. And who is this? The physician via telemedicine connects with a community paramedic who has significant experience, as seen here. So they do key assessments, provide medications, review home safety and coordination. So the structure involves my Department of Hospital Medicine, including myself, again, It's part, we think of a hospital home as part of our census. Say I have 15 patients, 3 of them may be hospital home patients. And at 10:30, 11 o'clock in the morning, my rounding involves an iPad that I'm going to use to call the paramedic who's going to connect with the nursing staff. And the on-site care is done by these physician extenders. And after hours care is done in tandem with a care nursing line. Back to our patient, the hospital home program was implemented for this patient. And what happens? And this patient ends up discharging that day from home, from hospital to home, with a couple liters of oxygen, with 4 more days of acute management. He got twice a day diuretics through the IV in his home environment with his family around him. When the paramedic came in, they're talking about the home medications, daily weights, getting him into the routine of care of congestive heart failure in the home. This program led to a shortened length of stay for this case, 3 days as well. So to date, we have some data, over 250 visits completed, 52 averted ER visits, 42 averted hospitalizations, and 57 shortened hospitalizations as well. And I highlighting here just that hospital home really can give a window into social determinants of health. And when I'm doing these visits and have learners with me as well, it's a powerful vehicle to say, yes, there's one thing you can ask them history, but you're visually seeing into their home here. And then connecting with their kids or a family member with their permission, right? And so you're see their loved ones and really learning about their support system. And again, 80% of a person's health is determined by the factors outside of the traditional healthcare setting. So home environment is key. And if you can get a window there and partner with them in that environment, it can be a powerful mitigator as well. So as we walk into the future, need to keep in mind that any disruptive health innovation, be it telemedicine or anything else, it takes time, validation, and the right catalyst before it becomes fully embraced across the medical community. So virtual care arguably will become the standard across all care settings. It's at least a subset. It's going to be a supplement, if not a standard as well. And so not only will patients choose providers, health systems, and hospitals based on telemedicine access, our next generation of learners will choose programs based on which groups have telemedicine, or are they being innovative? Do they have curricula on it? And so patients will get more accustomed to virtual care, and our health systems that lack access to care, arguably will also see decrease in patient volumes from patients choosing providers and health systems that offer due telemedicine. Oh yeah, that's right. Remember this quote? I agree it's valuable, but have doubts that it can be used regularly to take care of patients. It's cumbersome to use, takes time to learn well and use, and will disrupt the regular workflow. You're like, I didn't say that. Well, someone did actually. In our institution, when we're rolling out virtual care, we ended up having quotes like this come up. I do not want to use that iPad in that encounter. I just think it's troublesome, it's cumbersome. How am I going to learn this? Is this even the future, right? But it's the same resistance that seems really familiar, right? It goes way back. We talked about the stethoscope. Same resistance was there, but over a period of time, it is the standard. We use stethoscopes in our evaluation of patients. How much more virtual care or tools like maybe bedside ultrasound, other things can be coming into play. I would challenge us to consider a few terms here in the last 5-10 minutes here. Are you a digital native or an immigrant? The terms digital native and digital immigrant were invented by a gentleman named Mark Prensky. He proclaimed that digital natives and digital immigrants perceive and use technology in different ways, as well as in learning. So people who were not born in the digital era and later adopted new technology are named digital immigrants, whereas people who are born during or after the digital era are dubbed digital natives. So you're asking what years? Well, generally digital era begins around 1980. So adults age 40, 45, 41 and above are categorized as digital immigrants. So in recent years, though, there's been some research claiming that, well, these categories are not that binary. You should be grouped along the spectrum. And I tend to agree with that, right? Based on comprehension and understanding, comfort with technology rather than just age. So here are the 4 groups. Avoiders, minimalists, eager adopters, and innovators. All right, so avoiders, who are they? They avoid the use of modern technology, right? You could stereotypically think, all right, that's the older generation. Yet I've not seen that hold true at all, really. There are veteran, late career educators who embrace modern tech and virtual care better than any early career that I've seen. Conversely, younger generation who are not willing to adapt, they're avoiders. Minimalists, who are they, right? They use technology reluctantly. So they prefer traditional means. They say they don't trust the electronic mediums. There's many subgroups, right? There could be digital immigrants who are reluctant adopters, or digital natives who are minimalists, right? You're like, you lost me there. Well, the main point is that there's tourists, people who feel like visitors to a digital world. So if I were to teach a bedside ultrasound course, some people may say, I'll just take a course. Yeah, and I don't know if I want to do it anymore. They just want to get a sense of it, but I don't want to do. So what minimalists do, they pay attention to the local culture, learn the language just a little bit. So habla español, that's about it. I don't want to go further into that. Observe its rituals, comprehend its complexities, but keep a distance from further things, right? But eager adopters, enthusiastic or eager adopters, they eagerly enjoy technology, right? They participate in online discussions via social media, maybe get into the world of professional use of Twitter chats or blogs or online education. They want to adapt. They want to try new technology mediums. They find it interesting. And finally, innovators. They're not only enthusiastic, they will work with the technology to improve it. Those are innovators. That's the field equivalent of game developers, programmers, engineers, technical writers. So the question for yourself personally and this group, where are you at on the spectrum? When you hear a talk like this, it's like, I want core bread and butter, internal medicine, grand rounds. This was virtual medicine. I don't know. I hear it's coming. I've used it a little bit. I kind of want to go back to the normal era. All right. Or where are your colleagues in your department? Where are your learners? Right? Ask those hard questions. I think it's important. It doesn't mean that going full board into one spectrum is the right answer. It's just, I think there's an evolution happening. And are we staying tuned to that and understanding where our spectrum is? As change management happens, where are we personally, where are people around us occurring as well? I've enjoyed this. Hopefully you're enjoying this as well. The future of medicine involves virtual care. So as our takeaways occur here, the COVID-19 pandemic demonstrates virtual care is going to be instrumental, right? I would think the curriculum for healthcare trainees, our staff, should incorporate telemedicine competencies. Telemedicine patients should be risk stratified in terms of, to obtain the highest utility, needs to be a clear decision process. Which patients should be seen virtually? I think this involves, clinical criteria and also patient-centric criteria, right? Those who are hard of hearing and those who are maybe end-of-life discussions, there should be some caveats. Unless that's the only resource, consider that in-person evaluation is needed. Virtual communication requires new communication skills. So seeing patients via telemedicine mandates a different skill. Again, the concept of Webside Manner, right? To build that patient-provider relationship. And don't forget, health disparities could be further exacerbated, right? Equity and access to care in health applies to telemedicine as it does to any other element. So let's keep equity at its forethought. If you like additional resources, feel free to refer to some of our work over the past year, publication in the Journal of Hospital Medicine, and then an article with Dr. Doshi on the topic. There's a lot of literature out there. Happy to share a slide deck to whoever manages this. Thank you very much.
Benji, thank you so much. Questions from the audience?
Dan, I think there's a great question in the chat here. What evidence do we have that patients prefer telemedicine visits over in-person ones? And the asker notes that their telemedicine rates have declined in recent months, which I'll say I've also seen at our setting. Yeah. That's a multifaceted question. I think in terms of patient preference, the biggest data comes from Intermountain Health and the Utah study that I shared there. There's other studies that are a little smaller, and it really looks at outpatient environments primarily, but the inpatient sector is also being studied. The paper we looked at has some descriptive data on there as well. So patients' preference, but if patient's experience is what we're looking at as well. I think that terminology may
be a little semantics there, but I think at level patient experience is equivalent. In some regards, it may be superior, but the patient preference is a unique one. In regarding to who payer piece, I got a couple of questions coming in on payers. Let me just make sure I'm reading it correctly here. Telemedicine rates. Let me just I'll cover multiple things at the same time. So maybe for this context, I'll cover the hospital at home. I see a couple of questions on that. For hospital at home program, this isn't a finance talk, but we've reviewed our various payers, the payer mix, the case mix index, and the payment per case mix index to extrapolate some financial projections. And so basically the cost estimates really show that the overall net margin is rather positive and makes for a great case for the viability of the program from a value-based organizational standpoint. Because if you're taking revenue from the hospital and going into the patient environment, the hospital may lose that revenue, but who's going to gain? So if you look at it from a population health standpoint and a system-based standpoint, there's a win. But you have to get to that winning argument. Is a hospital working in silo, or is it going to work in partnership with the system? Your question on hospital home program, who's paying for it? That's kind of where it comes from. I think I may just get at the concept of billing and reimbursement from a pre-pandemic era. So pre-pandemic services needed it to be in the health provider shortage area, HPSA. Remember that term from way back in the first slide, second slide. Patients need to travel from a originating site, not from the home, to get the payments. In the pandemic, there's a bill. These things, unfortunately, are memorized now. 6074 is the bill. It's a wide array that's allowed. So modifiers can be used. And so there's an important bill in front of Congress right now, HR 7663, Protecting Access to Post-COVID-19 Telehealth Act of 2020. That will remove geographic restrictions, allow more flexibility, and I think it'll allow that conversation to go further on. So I think it's a complex question. I'm happy to take it offline. I think there's a tension there, and I would think there's going to be a medium here where payments, insurers will need to go somewhat in between. Maybe not giving the same amount of payment that we get for a hospital stay for the hospital home, which is we're actually getting a pretty good rate right now. I don't think that's the most just. There's probably some in between because the overhead in the home is much less. So I think down the line there's going to be some in between. So more to come, probably the latter half of this year. How's that for a quasi response? All right. I'll try to keep reading, but there's a fair bit here.
I think another point that was raised by Dr. Del Rio and that I would raise as well is, I think many of us have heard, for example, Abraham Ferdis's TED Talk on the power of touch and the healing power of ritual and touch. And I guess I'd ask you to sort of comment on relationships with patients and touch as being a component of care that is lost in this setting.
Yeah, great question. I see that question as well. It is challenging. I think at some level, so this is that concept of presence, right? Is it touch in through an electronic medium? Is there an equivalent for that? When I started in telemedicine, it was pre-pandemic in resource limited settings. That's how it started. And that's when care could not be delivered. There was overnight coverage in a remote area in Wisconsin or Minnesota. And we are the only docs that are available in that setting. And we would, rather than driving in, 100 miles and then rounding in the hospital the next day, we would call in and provide that care. And how we optimized it was this concept of telepresence, where the screens we invested in are pretty large in the patient's room. The bedside nurse becomes our best hands and feet. They have a checklist-based physical exam they walk through, and we train them on site in that process. We have a remote stethoscope. When they put it on the patient's chest or bosom, we hear it through our audio. And the ways I interact with them I try to use my hands. I'm really focused on them. The things that can be missed are end-of-life conversations. I'll give a humorous anecdote. It was like 11 o'clock at night. You try not to have goals of care, critical conversations at certain times of the night, but this is what happened. And we needed to move that conversation along. And the patient started crying. And there's a lot of emotions involved. And I see this through the side of the computer, a Kleenex box coming in. And it was my bedside nurse who sensed that and became my hands and feet and provided that. Now, it seemed a little awkward for me, right? I want to be there in person, put some touch and support, but yet the patient received a supplement or complement. Now, is it superior? I think that's where it's, you have to risk stratify. And I think as a supplement and not a complete alternative is probably where my personal biases land on where telemedicine can supplement. I think patients, by seeing them multiple times a day, being able to update them with a face, otherwise, many times we don't update our patients well. We don't even talk to them. We move from room to room. I think we get more quality time with them that can arguably get at some of those tensions of touch. There's some literature on the topic, and I think telepresence competing with human touch is at stake here.
So Benji, maybe we have time for one more question.
Okay, maybe I'll tackle Jennifer Carpinello's question. There's been research in CHF on remote telemonitoring and reduction of readmissions and improved compliance, mostly using RN and APP with supervising physician. Do you think we should target a disease in populations with high readmission rates for use of this tech? Great question. Exactly the type of work that I think we should focus on. In congestive heart failure, if you were to have a baseline of, hey, this is their length of stay, say it's 4.6 days, observed and expected, whatever your data shows. And then in implementing a hospital-based program with a defined checklist, say at 2 liters of oxygen or less and stable requirements of diuretics, this patient can go home, right? And then having diuretics once or twice a day. And that'll mitigate things, but also help them with education on the front. So big bucket diagnoses like CHF would help. COVID is a big one that we focused on as well. So, and we're doing other big buckets like that. So that's great. I like that. I think that's last question for Dr. Hunt here. So thanks, everyone.
So Benji, thank you so much for a terrific presentation. A lot of discussion in the chat. Yeah, so there's a lot of interest in this area. And thanks again to Wendy and the organizing group for allowing us to have Hospital Medicine Visiting Professor Grand Rounds. Thanks to everybody for attending.